listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years experience. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone back to the Medic Materials Podcast. So Gerard, I didn't hear any type of seizure activity from you or grunts or groans or nothing.
Oh, I cringed. it was a visible cringe.
Yeah, well, you know what? Hopefully soon we'll be visible to see your cringes, and then
That would be nice. Yeah.
It'll be
In
even
fact, I
more
probably could have made
hilarious.
it today, but I didn't have enough Brandon in my gas tank.
You know, it's funny you say that because I went to Stewart's to fill up my my little like 2.5 gallon can, just so I could fill up my tractor to mow my lawn. And I looked at it and I was like, you know what? I could fill up my tank, but I'm not going to.
Right.
Yep. Like, screw that. I could make it a couple more days. By then it'll be like 5:15. So who the fuck cares?
We're at 5:09 now.
Yeah. Oh, it's miserable. Absolutely fucking miserable. But anyhow, so it's going to be an interesting episode today, Gerard, because Kelsey is not here. She's out doing her medical internship with the Fosternator. And and Emily is not here because she is working today, and this was the only day that you and I could get together. So, reluctantly, I have brought
I can't
back,
believe she chose money over this.
You know, it's true. You know, how savage of her. In the,
right?
You know, it's just not
very
fair.
Selfish.
It is very selfish, especially to make us have to deal with my least favorite person on the planet right now.
Kelly, Kelly, K-E-L-L-Y. Why? Because you're Kelly.
This song never gets old.
It always gets me right at that stop.
But
it's because a picture of Woody Harrelson pops in my head. I'm like, oh, yep.
Slow
Tallahassee.
clap. Absolutely perfect. But we're also joined with two very special guests. Ariel's here, who has been on the show before, both on Patreon and on the free show. And you brought a very special guest, didn't you?
Yes, I did. I brought with me my boyfriend, Greg, who is also a paramedic.
Yay! So Greg is a fan of the show. You've been listening for quite a while.
Since the beginning.
It's just so far long ago. Like, that's
Dude,
the scary part.
I just thought of it. We need to have a theme song for when we're status paramedicus.
Dude, yeah, right?
You know?
So I
didn't even think about it.
I have
We've got a badass over here.
That's it. You know, typically it's Emily's, you know, thing to shut her up about EMT badasses, but, you know, we'll use it for us today. So reluctantly, I'm going to hand over the rig check to none other than Kelly today, and then we're going to get started. Yep, I'm going to do it. It's going to be fabulous. Kelly, do your rig check since Kelsey's not here, and then we'll do the call review.
Really?
Really?
Fascinating. Oh, no shit, Finland. All right, cool.
We love Finland.
Scroll.
So,
All right. Good stuff.
Yeah.
Okay,
Kelly?
everybody got all that? The website and where to find us?
got it all.
Good.
oh, it was Kelly. That was absolutely perfect. You get a
Stunning.
you get a ka-ching for that one.
She nailed it.
She did.
Yeah.
You know, she always nails it. Typically on her back though, but it's okay. So, anywho, damn. So,
My Italian came out for a second. Oh!
so let's
Practicing the vowels.
So let's dive right into this call review. So your guys' system, today's call takes place in a rural district, which is covered by a town ambulance service that staffs its rigs with numerous levels of providers. from EMT basics to intermediates to paramagicians. During this call, however, their rig was staffed with 2 intermediate providers. Due to the ALS, we're going to say ALS light nature of this, crew, a second ALS level agency in the neighboring town is used if they don't have any paramagicians on. So this ALS agency is staffed with a paid paramedic and a paid EMT.
Yeah, I don't know if they're both intermediates. I don't think it's necessarily light. I think it's more like diet ALS.
So one is light, 2 is diet. I like it.
Yeah, it's not ALS 0, so
that's
it's
true.
Light. It's
true.
diet.
There you go. So hospitals in the area, there are 2 within the immediate area. A local critical access hospital, approximately 12 minutes from the scene, and a trauma/cardiac center, approximately 40 minutes away from this scene. So you guys are being dispatched, priority 1 or a Delta priority, to a local apple processing facility for a 57-year-old male who is found to be unconscious. Both agencies are dispatched to the scene. So the intermediate level agency and then the ALS level agency. So
do they sell pie there?
What was that?
Do they sell pies there?
I don't know, but who knows? Maybe
that would change the whole dynamic of the call.
It would. It definitely would.
Yeah.
Well, because one person can take care of the patient, the other person can go get pie for later.
Yeah.
But apparently to management, we can't order things if we go to businesses. It's frowned upon, so. We're already there. We can't order. What's the point?
I feel like you're tossing like a shoot promo here. Like something is angering you.
Just wanted my order that day.
Because here I'm thinking like pie. I'm thinking, The Rock going pie, la 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 la. Like that's what I'm thinking in my head. Like we're gonna go get some pie. Which is funny because I was sitting there. Funny story. This is just becoming a wrestling/EMS show. It's guaranteed to happen. But anyhow, so I was sitting there having a conversation with Jess at one point, and she had brought up like pie, and I was like, "Yeah, poontang pie," and she's like, "What?" It completely just went over her head. Had absolutely no idea, and I was like, "I'm sorry. I'm sorry. Like I can't. Yeah. I just can't."
Just blame me.
Yeah.
It's all G's fault.
G's joke.
Blame me.
So if you guys are the ones being dispatched to this type of call, like what are the things that you're thinking about initially driving to the scene? But then how does this particular sort of scene, like a processing type facility, like a factory type place, how does that bring up any type of concerns in the back of your mind that you're going to have to deal with?
I mean, right off the rip, I'm thinking it could be some kind of chemical leak that we don't know about, especially with it being at a big facility. Something definitely could have leaked out. Well, one of the things I would want to do is if anybody else is presenting with similar symptoms, just to kind of get a scene safety aspect of it.
Right. Yeah, because like who knows how many employees are there? Why is one person unconscious? Next thing you know, you have an MCI of 70.
Yeah.
It's like, that's going to be fun.
And we're at risk too. So I'd definitely find out if there's any possible like leaks that could be, happening as soon as we got there.
Absolutely.
I would think, where is this person
Hello?
located?
You're still there.
Oh. Something's going on with this damn thing.
Oh.
My bad. I didn't hear.
He more or less said MCI chemical stuff.
Yeah. Heard all that.
Okay.
But kind of crapped out a little bit there at the end.
Are you playing your
For
flight
whatever
simulator?
reason. No, I don't think it was him. I think it was
He's totally
whatever.
playing his flight
Internet.
simulator.
He definitely is.
He definitely is.
I just heard tower control in the background.
Right. Oh, gotta love it. So you were saying, Ariel?
Where is this person located? What kind of equipment am I going to need to get to them? If it's a factory, are they inside of the factory? How do we navigate through it? If it's a factory, like what type of machinery do they have there? Is it going to be easy to get the ambulance back to wherever we need to go? And how long it would take to get the person out of wherever they are if they're not just in an open field.
Right. This isn't going into a residence. Like, how do we even have access? Like, are we walking in through the front door? Are we walking in through an access door, like a bay door? Like,
so
exactly, how are we going to extricate out? Is it safe for us to even be in?
It's a different type of scene size up than
It really
than
is.
what we're normally used used to.
Yeah.
Even maybe like considering like maybe crowd control. Like I don't know what kind of facility this is, how many people are going to be there.
There's going to be a lot of employees. So yeah, that's a good point.
You would think, right? Do they have, and if it's a large facility, some like, big facilities like that even have medical staff on scene. Yeah. Are they rendering some type of care or something before we even get there? So during the response, both units are updated that the patient has stopped breathing and CPR instructions are now being given through dispatch. About 4 minutes later, the units are still en route to the scene, but county comes back on and updates the units that an AED was applied and 1 shock has been delivered. So knowing the updated information, how does your preparation go in medically? We're still thinking about all the scene size-up aspects, but now how does your medical thoughts go in from unconscious to now CPR to AED to shock being delivered?
And can we just confirm the patient's age?
50-something. Stand by. Hold on. 57.
Okay.
One of the things I was thinking of going in on our way was, could this have been a trauma? Did they head into a forklift, or did a forklift run over them? Something like that.
Yep.
It's an industrial place. So, is this a medical arrest or is this a trauma arrest?
Right.
Absolutely.
Did some kind of weird accident happen? And hey, look, they're laying on the floor, but Joe Bob driving the freaking forklift is just fat, dumb, and happy with the fresh marks on his tires.
No, it's and I was even thinking, what type of processing do they do there? Like, is this cutting, scoring, chopping up? Like, is this trauma related in the course of, like, maybe he got a finger chopped off?
Does he have an arm?
Like, does he have an arm and now he had a sudden loss of blood and went unconscious from that, or whatever, Yeah,
because you can't always rely on what dispatch tells you.
Right.
We know that. So.
Right. So, any thoughts from you in the new?
Just thinking about all the equipment I got to bring in now.
Oh, I know. Like, this is, where can I fit my stretcher? Because the stretcher's going in with me at this point. Yeah. Like, it's guaranteed. So the crew of intermediates arrive on scene, and they grab their what we're going to say is ALS light bag, their cardiac monitor, their first in bag, and they enter the facility with their stretcher. So one thing that they didn't bring that I
Suction.
Bingo, right?
Mm-hmm.
So they enter.
That's right.
Yep, they're led in the facility, and they're brought onto the factory floor by another employee who meets them at the door. During the walk, they were told by that employee that the male was working on the facility floor when other workers saw him collapse. They attempted to wake him up by shaking him, and nothing happened. This is when they attempted to find a pulse and could not find one. Bystander CPR was started, and the manager ran for the AED. The crew finally gets to the actual factory floor, and if you can picture it, there are 3 like gargantuan machines, one in the middle and then 2 flanking it, that are almost 50 feet in length, lining the room. And the noise in this facility is legit deafening from what I was told. So, like, you cannot hear yourself talking out your own mouth. It's that loud.
Now, does it sound more like gears operating or more of a voltage sound?
No, this is like machinery operating.
Going, okay.
Yep. So
Can we shut it down?
So no one actually does. This just keeps on running. I don't know if this was one of those types of situations where you could have. I don't know, but they don't fix the noise issue. Yeah. So they walk over to where the male is laying on the floor, and he's surrounded by workers. And when they finally get through all the workers, they find them awake, eyes open, breathing fast. So now what do? We can't hear. Apparently this guy was in cardiac arrest, or at least what we think was cardiac arrest, and now he appears that he's awake and alive.
Or was
we
he
had
passed out and they thought it was cardiac arrest, so they thumped on him and he ended up coming back anyway from whatever reason put him down, you know?
And
Yep.
then when they were thumping, the
So we
AED
don't
picked
know
it up
what's
as a
going on.
shockable rhythm.
Right. Did they analyze the, is the shockable rhythm the analyzation of the CPR, or is it they stopped and they actually did it right?
Yeah.
Right. You
When they
know?
shocked him, did he say ow?
So I can actually answer that question. No, he did not
Oh.
have any response other than the typical flinching of, muscle,
The twinge.
right.
The
So-
lift, I call it.
Fasciculations.
Yeah.
That's the word I was looking for. And I got that one out without a buzzer. Bingo.
Look at the big brain of Brad.
So yeah, like what are you there's a lot to be thinking of. Like I've walked on arrests that were arrests and then I walked there and I'm like, this is not an arrest, stop that. Like this is you're there after all the fun happens. Like was there a rhythm that changed? Is he actually like there's a lot of questions at this point. So we're gonna call him the lead intermediate, realizes that they can't do a proper assessment or interview in a room where they can't even hear themselves speaking. So the crew makes the motions, like the hand motions for him to get up and like move over to the stretcher. So like get up, move over there. So
Okay.
yeah, so Ariel, you're giving me a terrible look.
I don't like that.
Wow.
I don't like that.
You're good now, right?
I don't like that at all.
You're good, right?
Yeah, you're fine. Sure, sign here, press hard.
Let's walk and talk.
So the male stands up without issue, begins to take a few steps, but when he does, he stumbles a few times like he's losing his balance to the point where employees and the other intermediate have to catch him. And then
With all those hands, you could have just carried him.
Right.
you absolutely could have just carried him, right? So
And you said he was working to breathe while he was on the ground, so I'm sure that
So it's right. It says that he's breathing fast. It doesn't say, how fast or how labored that, tachypnea is, but he's breathing fast, So let's, and my theory and thought process is why are we making the guy who was allegedly just shocked and in cardiac arrest work
Walk.
hard
Yeah.
and walk?
Right.
Like that just sounds like a terrible idea. So,
We need a theme song for laziness.
you know,
You know?
yeah. Yeah.
Yeah.
I think I will work on that one. I will totally work on that one. So they finally get him over the stretcher without having him hit the floor, which is a good thing. They secure him to the belts and they begin to move out of the facility. Now, again, use your imaginations here. As they're moving through this facility, his eyes shut and he becomes unconscious again. However, neither crew members actually notices this because one of them is walking away from him and one of them is walking behind him with the head up, so they can't actually see.
Yeah.
Nobody
Right?
put him on a monitor. Nobody
Nope.
did anything. Right?
Nobody
Yeah,
put
so
him
we
on
didn't get
anything.
Vitals yet.
Nope, no vitals,
Fantastic.
no nothing, right? So he becomes unconscious again. They don't know until they're outside, and they flip him around to put him in the back of the rig, and they're like, "Oh, look, he's not conscious. Sweet." So they put him in the back of the truck, and then both intermediates get into the back of their ambulance. They immediately go and they do a pulse check, and they find no pulse present.
Oh, Lord.
So there's also
How long did it take to get out there?
I was going to
Yeah,
say
I
5 to
was about to say
7.
that.
yeah, at
probably.
least right. You're thinking 5
That's
to
nice.
10-ish, right?
That's all.
So
They could always use the nursing home line. Well, he was fine 5 minutes ago.
Oh my
Right.
We just got a blood pressure.
Right.
There's lividity.
Right,
No, you
right.
didn't.
yeah, right, exactly.
No, you didn't.
I
Oh, we just saw him walking.
right. They were fine in the chair in the hallway. So they attempt to find pulse, find none. There's no breathing present, and he is fully unconscious, unresponsive. So the secondary intermediate begins manual CPR, and the primary intermediate has to rip off the AED pads that are actually on him because they don't fit their monitor. So They rip them off. They place their own AED pads. The cardiac monitor's turned on. It's set right into AED mode, and they analyze. Shock is advised. They charge, deliver 1 shock. Why are you seething over there? You're being like Emily here. She's usually twitching in the corner and like seething and looking at me like, why are you keeping to talk? Like, stop it. I hate this.
Yeah, this is like mortifying right now.
Yeah.
But I would be lying to everybody if I said I was never on a scene like this. Like, we've all been on scenes that happen the same way. Just like, oh man, they were in arrest and now they're not. Now they are, and everything goes fucking bonkers. Yeah.
But I can honestly say I've never had somebody that was in arrest that came out of arrest and I said, hey, let's stand up and walk.
That's 100% accurate. Yep.
Stretch it out.
Even if it's just a reeve straight up to the stretcher,
And like
it's
and
minimized.
I understand like you can't do an assessment in there because it's loud. But if you have a long walk back to the ambulance and this patient was just unconscious and he was defibrillated, just put a 4-lead on, a pulse ox, something, so that you can see everything that's happening as you're walking.
I would get a first set.
Vitals real quick.
Personally, I would get a first set, even if it is loud, just to get that baseline of where we're at.
Yeah,
right.
Absolutely.
But here's the other thing too. Now this goes back to I don't know what the intermediates were able to actually do in terms of cardiac monitoring. So like here in New York State, they're not allowed to use a 4-lead or a 12-lead as an AEMT intermediate. Mm-hmm. They can use the AED mode, they can do all of their shocks and stuff like that, but putting on the leads and going, oh, that's a normal sinus rhythm is not in their scope.
Well, at the very least, slap your pads on and have your monitor ready to go.
Well, absolutely. I'm not defending what they did, but one of the things that just literally popped into my brain was they had a conversation with the employee who brought them into the facility while walking through the facility until they got to the actual operation floor. Why couldn't they just stop in the hallway and do all their stuff there?
Right. Yeah. I mean, like I said, my preference would have been shut the machines down.
Yeah. Right. Or hey, shut the machines off for 10 minutes.
Yeah, get to a place where you can talk.
Right. Instead of, oh no, we can't do anything in this building. We got to make it outside. I think that was
we can't do anything in this building. We can't take a set of vitals. We can't do anything.
Right. I think there was severe lack of planning there.
And they could have taken a manual BP and they could have taken a palpated pulse.
So I'm big on palpated, especially when we're moving. You really can't hear that well, but palpated, you can feel that pulse stop and go. So
yeah, exactly.
But with the manual BP, we all know how to count ticks, don't we?
Yeah, and
when the thing stops ticking, and when the thing stops ticking, there you go.
At least
it'll get you in the ballpark.
Bingo, exactly.
So
they have this shock advised. They charge, they deliver 1 shock. So now they're up to 2 shocks, I believe, right? 2 shocks.
First one before we got there.
Yep. So the primary intermediate then places him on 15 liters per minute oxygen via the non-rebreather mask, and then moves to place an IO in the left tibial plateau, where they get some aspiration of marrow, but not like a full, complete saline well.
Did we even try for an IV?
Nope. Just went straight to the IO.
Okay.
They choose to go they choose to go with that IO site and not try for the IO or not try for like another IO or IV or anything like that. But they also choose not to secure it down with any type of like tape or commercial device or anything. They just leave it out hanging. They do connect the 1,000 bag of normal saline, spiked with 10 drop set, and then they secure it to the IO with the pressure infuser that they have. So awesome for that. So then they're still doing CPR, and time for the next rhythm check rolls around. Yep, you're mortified. It's okay. You're allowed to be. And they stop to let the monitor analyze. Another shock is advised. So they charge and they deliver a second shock. So we were calculating shocks. I wrote it in here. Apparently, there were 2 shocks given prior to EMS being there, and now this is
Okay, so
2
it's
for
3.
them. So this is 4.
4 total.
This is 4
4.
total. Yes,
2 EMS, 2 pre-arrival.
correct.
Gotcha.
So they deliver this 4th shock, 2 for EMS. The crew switches providers, and CPR is again continued. The secondary intermediate then goes and administers the first epinephrine through the IO, 1 milligram to 1 to 10,000.
So did we get 2 more shocks in before we gave the epi?
So you got 2 shocks before you gave the epi. Yep.
Okay.
Yep. So at this point in time, the paramedic truck arrives on scene. The medic grabs their monitor, airway bag, ALS bag, and enters the other crew's ambulance. A report's given by the primary intermediate, who's doing CPR at this point, and they pause and do the initial rhythm check for the medic, because the medic's like, hey, I want to see what we're dealing with right now. So they pause. No shocks advised on the analyzation.
Quick question. I may have missed it.
Yep.
Did anybody ever secure the airway and bag this guy?
Nope.
No, there's a
I
non-
was-
there's
a
I was
non-rebreather
waiting for him to
on his
finish,
face.
Yeah, I
Oh,
caught
well,
that.
that works.
That's why I'm.
I was going to
Yeah.
bring that up once he finished, that the non-rebreather
Yeah.
is probably like 8 minutes in. We should have been bagging a lot.
Oh, yeah.
The LPA.
Right?
Yeah,
This is like,
coded.
oh, yeah, they're fine. Just let it go down their throat. It's fine.
Or like we discussed previously one day, the bihemispheric oxygenation, just stick it in his ass.
You totally could. 100%.
I
You know?
I still haven't made the sticker for that.
You get the same result.
Absolutely.
I'll take 2 of those.
You just got to pay double for that kind of action, Kyle.
So the medic and the primary EMT or primary intermediate check for a radial and a carotid, and they find he has both at this point.
Yay!
So
Now get up and walk over to the paramedic truck.
With your non-rebreather on.
right. Yep. So what are your guys' thoughts with how this is going so far? Like, how is this call progressing? And in your guys' opinion, like, where does the immediate focus need to be going forward from here?
I would definitely
Ross.
say securing that airway.
Yeah.
We do have Rosk. However, what's his mental status like? We don't want him to recode because he goes re-hypoxic if that was the issue.
Right.
How about a
and,
full assessment?
and
Yeah.
we don't even know what rhythm
He
this
did.
guy's been in for the entirety of this
time,
because
yeah.
it's been AED mode. So we
Yeah.
have we can assume that there have been
'cause
shockable rhythms,
The
but
medic's checking and he's got a pulse now. So
right, we have no idea. Like, he could be still in a VTAC. It's just pulsed.
yeah.
You know, we don't know.
Yeah.
So yeah, I think airway concerns, definitely full, cardiac and, full assessment is
Yep.
it needed to
With
be
a
done
12
20
lead.
minutes ago.
Yeah.
Yeah.
Right. Vitals haven't even been done yet.
I don't think that
Like nothing.
before the medic truck got there, either one of the intermediates really had set tasks that they were doing. Like, it wasn't clear what each person was really doing. It seemed like one person was kind of working on some of these tasks, but the other person really was only doing CPR,
Right.
Right.
and it just all over the place.
Yeah. I definitely think somebody needs to be the voice where, like, you do this, dictate those roles.
Or at least maybe in a different order of things.
Yeah. Like, we're going to, yes, like, we need to secure an airway. Let's see where his mental status is. Let's get a full set of vitals.
Yeah.
Like, let's get him on the 4 lead, the 12 lead. Let's get a blood pressure. Let's see what his end title is, all this type of stuff. So the medic tells the intermediate crew that we're going to start getting going with the transport. Like, let's start boogieing. So the medic's EMT gets into the truck and will transport with the medic and one of the intermediates. So now you have an intermediate, a medic, and an intermediate in the back of the truck. And then the other intermediate drives to the cardiac center approximately 40-ish minutes away. So as they're leaving, the medic connects them to the ALS cardiac monitor and switches over the AED pads because they're compatible. The initial 4-lead EKG shows a sinus tach with a rate of 129. The EMT then begins to obtain baseline vital signs, which, awesome. Thank God somebody's finally doing it. They return as blood pressure via the auto cuff of 155 over 69. A respiratory rate of 12 and shallow. An SpO2 of 97%, still on that 15 liters. And
it worked.
Yep.
Yeah, I mean, now I would
Now
say
it
it's
is.
okay. I would say it's okay now.
It is now. Who knows what it was when they were
Yeah.
hypoxic and dead, right?
Oh,
It could have been
Details.
70. Who knows? So the medic, gets right in there and begins their first assessment of this guy. So they find that his mental status is beginning to improve slightly. He's starting to respond to voices and opening up his eyes while kind of like reaching out aimlessly with his arms. Airway appears clear. No fluid or debris is noted within the airway. Breathing is shallow, but seems as though it's return. I'll hit myself now.
There you go.
Thank you. Returning to normal in like depth, so it's not so shallow. No bleeding is noted. He is pale and extremely diaphoretic, and no trauma is noted anywhere to the body.
I definitely want to get a 12 lead pretty quickly. At this
Yes.
point. I'm thinking more.
12 lead and a PG, please. Thank you.
Yep.
Absolutely.
Agreed. So the EMT is right with you guys. They connect the 12 lead cables and run the first 12 lead. So when you're looking at it, it returns as AFib on the monitor, no longer sinus tach, but an AFib at a rate of 136. ST segment elevations are noted as follows. 2 millimeters in lead 1, 1 millimeter in lead 2, 2 millimeters in AVL, 6 millimeters in V2, 7 millimeters in V3, 6 millimeters in V4, 3 millimeters in V5, 1 millimeter in V6, and ST depressions are noted in 3 and AVR.
So almost global.
So, right.
So AVL was actually elevated then, huh?
AVL was elevated 2 millimeters. Yep.
Wow.
Yeah.
Okay.
So what are you guys dealing with here? And then how are you guys specifically going to proceed? Because, I mean, we have global elevations, the only...
Well, this is obviously this is a UTI.
Absolutely. 100%.
All the signs point right to it.
Right? It's obvious. It's plain as day.
I mean, that's it, guys. See you next month.
Yeah.
We're all done.
We're
here.
good.
Gerard fixed it.
On the next episode.
But yeah, I mean, you're looking at, lateral wall involvement. You're looking at anterior involvement. You're looking at septal wall involvement. You're looking at a large percentage, especially with, you're looking at 7 and 6 millimeters just in your anterior walls.
Yeah.
Alone. Like that's big.
80%.
Now, my
plus
question
easily.
question right now is how patent is that IO? And number 2, have we started any post-ROSC care?
No.
Medication-wise, calling a doc, whatever.
Nope. What you know is what I've told you, which is what they've done.
And what was his mental status?
Returning to normal.
Okay.
So eyes are starting to open up on verbal commands, and like I said, his hands are kind of reaching up and starting to grab stuff, but not really purposefully at this point.
Okay, so not 100% there yet.
No.
Okay.
No.
I
You're
would-
deep in thought over
Yeah.
there. Like,
I mean, we're obviously dealing with a blockage in the heart. So I don't think his mental status is good enough to have him start aspirin, but I think I would definitely start going down the morphine route with the hypertension, start getting some of that workload off of the heart. Maybe if he can tolerate, I don't know if I would go with nitro because of the severity of the elevations throughout.
yeah.
I might talk to a doc before that, but I would definitely get some morphine on board to take some of that workload off, get the blood pressure a little lower.
Is he able to talk?
I like it.
No. Not at this point.
So I want to give aspirin if he can't even swallow. I always have patients swallow 3 times, and if they can do that, then they can have the aspirin.
Yeah.
Yeah.
I mean, that's a great. I don't even do that. That's a I've never heard of anybody making people.
Yeah, just swallow.
Yeah,
Wait a few
that's
seconds.
awesome.
Swallow again. So
Yep.
that's how I kind of judge if they can tolerate
Yeah.
oral medications or not.
I like that. You know, and with something this big, we have to kind of plan out our next 8 steps.
Yeah.
Like they've coded twice. Now we see why, right? I'm sure there was some hypoxia that caused a VFib or a VTAC of some sort that was shockable, and then they go, oh, okay. We've already seen the progression from, you know, sinus TAC to an irritable AFib,
Yeah.
you know? So we really have to be not just thinking like, okay, we're going to give our aspirin, our nitro, our, you know, our type of like Mona protocol. But like Gerard brought up, where's like amiodarone and where's post-ROSC medications? And
How
like,
about some fluid?
do we have fluid going. We
Oh,
do have
do?
fluid going
Okay.
through the IO.
Gotcha.
But we don't have any type of like, you know, post-ROSC presser. We don't like nothing is prepared
I mean, we really
in
didn't.
senses of that.
We really didn't know the initial rhythm. I mean, if we knew they were in VTAC right off the rip, absolutely amiodarone drip to
Right, but at the
prevent it
same
again.
time,
Right.
right, we don't know, but can we assume
can,
because
yeah.
he's been shocked 4 times?
Yeah,
I mean, that's the only assumption that
I agree.
we can have
I agree.
in that sense. So what are we doing with airway right now? Do you guys want to secure it? Do you want to just leave it go?
How? So you said his mental status is increasing. He's grabbing at things. How is his respirations, and what is his SpO2? And is there a BLS airway in place?
yeah.
No BLS airway.
We can consider maybe an MPA. You know, if he's still eyes are kind of closed, slowly responding.
Yep.
I think I'm big on MPAs.
Me too.
we
Love
have-
them.
We have end title on.
Nope.
So yeah, anti. Yeah, that's a big one.
suck, you
I'm just-
I think he did mention that a while ago, but I don't think we
I
actually
think
said
like
it's
I think
on.
like right now at like this point, I'd be sitting there like, what else can I do? Can I like dry him off?
Yeah.
Because I don't.
Right.
I feel like I would already had that stuff on.
You would. These guys don't. And I think this medic is trying to play catch up too.
Yeah.
You know, from all this. But yeah, so like respiratory rates in the low, 12 to 14 range. SpO2's still 97 on that non-rebreather, the last that we know. So they're not awful.
Right.
It's not like he's breathing at 6, and we got to do something. I'm in that boat of, I think a BLS airway, like an NPA, is very intelligent at this point. Would I intubate this guy?
Not right now.
I don't think so.
No.
If my wife was here, she would be like, you're going to intubate this guy. But I don't always agree with when she intubates certain patient populations. So
I wouldn't do it right now just based on everything we just went through.
exactly.
I kind of want to hold what I got.
Right.
You know?
This guy's holding a 155 blood pressure. Like, in 10 minutes, is he going to be in the 60s? We don't know. Right?
Right.
And then I give him, all of my drugs for RSI, and now I plummet his pressure because, we
Right.
always give etomidate and sucks. So 100% we would not have dropped his pressure. So
And why do we give it?
because it needed a dose.
There you go.
Yep.
So brought to you by the folks at Matt Damon. So
Matt Damon.
So the intermediate transmits the 12 lead to the hospital and then calls the hospital to speak with the MD to inform the ER that they will be arriving shortly. The ER goes, cool, awesome, we got it. Yup, looks like a STEMI. Proceed directly to the cath lab. Sweet. So couple minutes goes by and the medic is now awake and beginning to speak to providers. The medic instructs the EMT to administer, at this point, the 481 milligram aspirin, and the intermediate to get out the nitro spray because they're going to go down the whole nitro path. So, medic then places a 18 gauge IV to the left AC successfully, and they decide that they're going to move the IO drip from the IO to the IV site.
I like it.
Yep. They're like, we want quicker access. We're just going to move this fluid. And at this point, it's at, a like full bore, wide open drip. They put it down to almost KVO, more of like a slow drip at this point.
Yeah.
Just to maintain blood pressure. So
Yeah, which is fine.
I'm okay with that. So at this point,
The only thing I might have done before getting the nitro out would be, while they're administering the aspirin, the EMT can do that. I'd get on the phone and get the doc. Start transmitting my shit.
Yep. Which they do.
Okay.
So they at this point, before any nitro's given, they run another 12 lead. Still AFib, this time with a rate of 121. Elevations are as follows: 3 millimeters in 1, 3 millimeters in AVL, 6 millimeters in V2, 10 millimeters in V3, 7 millimeters in V4, 3 millimeters in V5, 3 millimeters in V6. Depressions are now in 3, AVR, and AVF.
It's progressing.
So we've lost a few, but we've also gained elevations in places.
I'd go with the nitro at this point.
Would you, though? Because they still haven't done a right-sided.
Okay, yeah, that's fair.
At least, so
Get that confirmation first.
granted, you don't have an inferior MI here, but I would still do a right-sided in this.
Especially
with that much
as much
issue
elevations,
infarcting, yeah.
Exactly. Like, there's so much infarcting that this is where you go, let's do a right side, let's do a posterior, let's do all of them.
Too.
So the medic leans in, seeing this, second 12 lead, and they finally actually inform the patient, like, hey, you are having a giant, massive heart attack. It's cool. We're going to be fine. You're going to be fine. You're doing great. Cool. Which
You're thriving right now.
yeah, you're absolutely thriving. I mean, who can say they've been, right? Who can say they've been ripped from the grips of death twice?
True.
Twice.
Right?
True.
So
Did you see Elvis?
I was going to say Magic Johnson, probably.
right? So they proceed with the 0.4 milligram sublingual nitro spray, and he's still, complaining of a constant chest pain. So it is right. It's an all over chest pain. There's no, like, hey, give me a number, like nothing. I got nothing reported other than it's all over and it hurts. Yeah. So which is bonkers, because the next thing was crazy in that they were like, yep, you're having chest, and I guess I can kind of see it now that I'm having the conversation in my head. They were saying, listen, people did CPR on you. That's going to cause pain. But also you're having this giant cardiac event. That's going to cause pain. Like, I guess they were just trying to inform them of why they might be having pain. And I get that.
Are they giving him morphine?
No. Nope. The only thing
So we
they've
don't
given,
open our narc box.
the only thing that's been given so far is 1 nitro spray, 4 baby aspirin, and fluid. And oxygen. That's it. So
And are we still hypertensive, do you know?
we're coming up to another vital sign check.
Okay.
So he was 155. He'll lose a little bit, but he's still okay.
All right.
So he finally is starting to have conversation with the crew members, and they're like, hey, like, what happened before you don't remember anything? And he tells them that, prior to going back into work, he went out for lunch. He was sitting in his car having his, eating his sandwich, having his lunch. And he said he felt very lightheaded and nauseous while sitting in the car. During the period where he was eating his sandwich, he couldn't eat the sandwich anymore because he had vomited one time. He then returned to work feeling mostly normal, other than just being extremely nauseous. And now he wakes up here to where he can remember. So they ask for any type of medical history. He doesn't have any medical history. He's not on any meds, and he doesn't have any allergies. So fairly a good sign, other than the giant STEMI that he's having now. So vital signs are retaken. BP is 131/78. So again, not a huge drop. Heart rate is 140, still AFib on the monitor. Respiratory rate is now 18, up from 12, regular, no longer shallow. SpO2
Good.
is holding at 98%, GCS of 15. They finally take a blood glucose from the EMT, which returns as 298 milligrams per deciliter.
Not surprised.
Right, not surprised at all. I would expect it to actually be higher. So is there anything particular that you guys are looking to do for this patient with the findings that you're seeing? So we've kind of eliminated airway at this point, like he's maintaining on his own. But yeah, some form of pain management, whether I don't even care what it is. Give him some fentanyl. Give him some morphine.
It's going to break the anxiety chain.
Damn Skippy.
The more pain he feels, the more anxious he's going to be, knowing now that he is having a heart attack, and he's going to work himself up into another one. So
yeah, right.
Like, yeah, let's put him in his happy place.
Yeah.
Bingo.
You know, grandma with 2 pitchers of beer, and little people riding around on ponies.
With the alligator and playing golf.
Absolutely.
There you go. Okay, cool.
Don't forget Shooter.
That's right. But no, it really lends itself, and we're going to talk about why we give pain management at the end. But yeah, like there was, it almost seems like it was an afterthought. Like, I don't know if it was just not thought of or if they just chose, we don't feel like cracking our narcs today. Like, I don't know.
And it's not that much paperwork.
When you were saying before that they were giving him all these reasons why his chest hurts, how about instead of giving him reasons why his chest hurts, say, oh, your chest hurts, here, have some morphine.
Yeah.
Right. Yeah.
You know what I'm saying?
I'm with you.
Sounds like somebody didn't want to, pull the tag off the box.
And again, I can't be sure, but yeah, it just seems like it was either not thought of or thought of and be like, yeah, but I don't feel like doing that.
Right.
Which is really sad because I think pain management, like you say, Gerard, is a really good opportunity to help out your patient, especially in this type of situation.
And this man just coded like he's already having the worst day of his life.
Yeah,
right.
make him feel a little happy, right? Give him some ketamine; it'll be great.
Right?
I want some more of that.
I wouldn't, but I'm just saying. Give him the happy, the happy dragons in the sky. So the medic at this point chooses to take off the oxygen to see if he desaturates, which ultimately he does, but does not go below 91%. So oxygen is returned, but at this point with a nasal cannula set at 2. Oxygen saturations remain above 96% and will hold with the nasal cannula set at 2. So I'm good with that.
Happy with that.
I'm good with that. Another 0.4 milligrams of sublingual nitro is administered. Again, he continues to complain of pain in the center of his chest. Shocker.
Still no morphine.
Still no morphine. So at this point, we're going to fast forward through this call because not a lot more happens. That really
Did we ever transmit our stuff? Did we ever call a doc? Did we ever start any post-ROSC stuff? Did we do anything?
This is the second time I've told you they've called a doc. They've transmitted it. They're going to the cath lab.
That's because he was landing on his flight simulator.
That's right.
Well, I didn't hear it, man.
You had to switch over channels.
No.
Yeah, what's going on here? I'm on the wrong frequency. Hold on.
What?
It's fine. No, they did that. The intermediate actually did that before they gave all the meds and stuff. They had the conversation, said like, "Hey, we're coming." They looked at the 12 lead, said, "Oh man, that looks really bad." And
we'll see you say. I remember you saying.
Right. We'll see you in the cath lab.
Okay.
Yeah, you missed that whole cath lab. He was there, brought, and everything.
They did not, however, start any of the post-ROS stuff.
Yeah, the episode ended freaking 20 minutes ago. Where you been?
I'm pretty sure I know exactly where you were, and you were, sitting there enjoying your, frothy, stone cold Steve Austin's
Broken Skull IPA.
Exactly. We haven't plugged him in a really long time. I felt like
I know.
We needed the ka-ching button for a chance. So, So again, we're gonna fast forward because not a lot of stuff happens after this. He remains conscious, alert, oriented ×4. Vital signs remain more or less stable. The lowest blood pressure recorded was 105/66, but mostly maintained between the 110 and 135 range systolic. Heart rate maintained between 120 and 145, never converting from the AFib. He was given one more 0.4 milligram sublingual nitro spray for pain. Serial 12 leads are also obtained throughout the rest of the transport. I believe there was like 8 or 10 of them. The elevations and depressions all remain. The last 12 lead has elevations of 6 millimeters in 1, barely a millimeter in 2, 5 millimeters in AVL, 9 millimeters in V2, 13 millimeters in V10 or V10.
V10. Wow.
So I'm reading
All right.
past
Yeah,
where
that's
my eyes are. 13 millimeters in V3, 10 millimeters in V4, 5 millimeters in V5, 2 millimeters in V6. Depressions remain in 3 AVR AVF. The ambulance arrives at the hospital, proceeds directly to the cath lab. They offload to a holding bed there where they transfer care to the nursing staff. So before I give the update, final thoughts from you guys. How did this call go in your opinion overall?
Did we ever get any, like, do any more history taking other than I don't have any,
We really didn't get much history.
I don't take any medications? Did we anything about,
no
like,
meds.
was there anything, like unusual that day or anything that, was he in contact with anything that he isn't normally in contact with, or,
All great
just
questions.
you know what I mean?
Didn't ask.
I
Because
also
I don't. If they asked them, I did not get those answers. Let's put it that way.
Gotcha.
I think just thinking in my head with everything that was going on, just take a couple seconds and do a Cincinnati, because even if he's got a clot in the heart, another clot could break off and go towards the brain. So
Absolutely.
we could have two different.
You gotta do those 12 leads,
No, we've talked on this show before about patient presentations just like that.
Yeah.
Having the stroke, having the MI at the exact same time. It's something that you absolutely need to do. I think overall it was kind of chaotic.
Yeah.
I think there were a lot of moving parts, and I don't know. I think once the medic got there was a lot of delineation of tasks, which was good, but I also think that they just didn't hit the ball out of the ballpark. Let's put it that way. Like, there was a lot of stuff that they missed that even if they're not going to do, it wasn't even considered.
Right.
Yeah.
Like, again, no ROSC management other than fluid.
And we still never gave the morphine, right?
No pain management was given, no amiodarone,
Fantastic.
no lidocaine, no nothing.
So yeah, there was missed opportunity.
There were missed opportunities here, and I think that's where I don't know what they were focused on, because all of the crazy drama was more or less done
Time they got there.
by the time
My
the
guess
medic
is
got
going to be
there.
lunch.
Yeah, right?
Sorry.
So I do have an update here on this one, so kudos to me.
There's a first.
Shut up. So shortly after the crew dropped him off at the cath lab, he did end up going up for cardiac catheterization, and he was successfully catheterized and released the following morning. So
Nice.
the man done did made it, even with no morphine or fentanyl.
He's probably still in pain to this day.
He's probably hugging his little bear going, fuck, man, my chest still hurts.
Should have gave me that morphine.
But yeah, like it's one of those things, and I kind of wanted to talk specifically about like amiodarone, because we brought it up, and in the ROSC post care, it was clearly never given. I don't even think it was ever thought about. Like, there was no indications that they were even hemming and hawing over, like, let's give AMI, let's give lidocaine, let's give some sort of, anti-dysrhythmic.
Right.
But yeah, so I found some interesting facts about amiodarone and why we specifically give it post-arrest. So a lot of this you guys have already heard, but for those that might not have, amiodarone is a class 3 anti-arrhythmic drug. It blocks potassium currents that cause repolarization of the heart muscle during the third phase of the cardiac action potential. As a result, amiodarone increases the duration of the action potential as well as the effective refractory period of the myocytes or cardiac cells, which just means it elongates between beats, more or less. It
It
draws
basically
out.
pins the heart up against the wall and says, "Don't fuck around anymore."
Exactly. So, therefore, cardiac muscle cell excitability is reduced, preventing and treating the abnormal heart rhythm. So we give it post-arrest specifically because they were in some ventricular rhythm, because we don't want them to go back into the ventricular rhythm. So one of the things that I found that was kind of cool was after intravenous admin, amiodarone acts to relax smooth muscles that line vascular walls, decreases peripheral vascular resistance or afterload, and increases the cardiac index by just a small amount. Administration by this route also decreases cardiac conduction, preventing and treating the arrhythmias. So that's why we give it IV. Amiodarone ultimately prolongs the QRS duration and the QT interval. In addition, a decreased SA node automaticity occurs within the decrease of the AV node conduction. So it slows down the whole conduction pathway, increasing the length between beats. So this way, like, there's no ectopic pacemaker activity. So maybe if they would have given the amiodarone, they wouldn't have been in AFib the whole time.
Right.
Because amiodarone works on both the atriums and the ventricles. But we'll never know.
Slows down that conductivity, which is going to slow down that impulse.
Exactly. It's like the world will never know how many licks it takes to get to the center of a Tootsie Pop. We will never know.
Mr. Owl knows.
That's right. Mr. Owl does know. So, yeah, going into pain management. In this case, we've all said in length, it's never given in here. Why we give it, I think we've already discussed the fact that, it decreases the excitability of the patient, that anxiety. Anxiety leads to more hypoxia in the heart muscle.
It's humane.
Right?
Yeah.
Right, exactly. The one thing that we can do that we should be doing really well in this business is making people less suffer. Like, they should not have to
it's the
suffer.
one thing we can actually do and do well.
Right. Is morphine really good in MIs and STEMIs? Yes, it's fabulous. That's where Mona came from, right? It decreases the cardiac workload. It decreases the oxygen demand of that heart. So when your heart is hypoxic, it's not going to demand so much. So it's not increasing the hypoxia. So morphine is great if your blood pressure can support it. But also, I would be kind of on the fence to give morphine here because they never did that posterior right side. So there were depressions in the inferior leads through most of this call. There were some elevations in 2 here and there. So there's inferior involvement. And we have to remember that the left coronary artery and the left circumflex do feed portions of the inferior wall. We just can't
But they
see
were also given the nitro, so
right.
Why not?
Yes. In the case of we've already jumped that fence with nitro, I completely agree. Why not? If your blood pressure is going to hold, do it. I probably would have held off on doing any type of med until I got all of my 12 leads, and then been like, okay, I'm going to go with. I probably would have still given the nitro, but I probably would have given him fentanyl and fluid. That's probably the way I would have gone in this case.
Risk benefit.
Exactly. You're getting the bump in pressure from the fluid. You're getting the bump in pressure from the fentanyl, but you're holding it there with the decrease with the nitro. So, it's playing that.
Yeah, so you
it's
already
playing
have
that balance
something that's
game.
going to drop the pressure. Let's not double dose it and go with something a little more stable as the fentanyl.
Right.
I agree with that.
Yeah. But yeah, I mean, we need to stop being lazy. Gerard is 100% right. Like, there should never have not been a thought process like, let's make this guy comfortable.
As comfortable as fucking
I was just about to say that is you're 40 minutes and you're sitting there and he's crushing
40
chest
minutes.
pain.
Dude.
And again,
What, he started
with CPR,
Yeah.
with 4 doses of electricity, and with a massive MI.
He's sore.
Like, this dude's hurting, and we just was like, no, aspirin's fine. Aspirin's
No,
fine.
no, no, no. We
30
weren't
minutes
like,
will
no,
be
no.
better.
We actually said, oh, well, they were doing CPR, so that's probably why your chest hurts.
Right.
Right.
Yeah.
And maybe with the pain too, like it's probably got his heart rate elevated a little bit more. If you give him the morphine, it might calm him down. His heart rate might come down a little
Right.
bit. And
Exactly.
Just chill him out.
Yeah. It
It's the
is-
anxiety chain,
Right.
man. Pain causes anxiety. Anxiety squeezes everything, gets everything jacked up,
It does.
And it sounds
then-
like he was.
and then it causes more problems. So break the chain.
It
Yeah.
sounds like he was healthy up until this incident. So
Right.
imagine that he's scared right now.
Yeah,
Damn Skippy.
Worst day of his life.
And I mean, how many times do we hear from just the world that heart attack kills so many people, right? If you have a heart attack, you immediately go, I'm dead.
Yep.
The normal public doesn't realize, like, there's processes that will make me not dead.
Yeah.
They just go, oh my God, I'm having a heart attack, I'm dead.
This is it.
This is it.
Yeah.
I'm never going to see my family again, my kids, my wife, whatever, my dog, nothing. So yeah,
But you give them that fentanyl, you give them that morphine, they ain't thinking about that right
they're
now.
not thinking about it. They're thinking,
Yeah.
oh man, that feels great.
Wow, man.
So we brought up right side, we brought up posterior multiple times. So why do we do right side? Why do we do posterior 12 leads? It's been a while since I've done a posterior 12 lead. I just haven't had the need to.
Yeah.
I don't know of a lot of providers that do posterior 12 leads or even where to put them. They're like, oh, well, what are we even looking for? So that's what I really wanted to talk about, because right side, you more or less just move everything opposite. I do a full right-sided, so I literally just shadow everything on the right side of the chest, and I'm still looking for all of my, elevations in my inferior leads or my lateral leads, again, because
You're mirroring.
they're mirroring.
Yeah.
But you can be lazy and use V4R. I don't particularly like to use that because it's less information.
That's how I was taught. Move
But-
V4
but
right
yeah.
over, and that's
Yep,
it.
and it is completely acceptable. I just think you get less information.
Yeah, absolutely.
But a posterior, so a posterior, you can actually do a full 12 lead, or so you literally just put 1 and 2 on the tops, like literally just draw a line from where you'd put them 1 and 2 on the front, and you put them on the back 1 and 2, and then you're gonna go 4, 5, and 6. You're gonna place underneath the left scapula and go around towards 6, like the original V6.
Yeah.
So that's how you kind of do your your full posterior 12 lead. Or, and this is the way I kind of do it because it's a whole lot easier, is you can just move 4, 5, and 6, and you make them V7, 8, and 9.
Yep.
And so if you can imagine, and I will make just because we're talking about this, I will make a post to put on Facebook and Instagram so people can actually see the placement. But V7 is placed on the left posterior axillary line. V8 is placed on the tip of the bottom of the left scapula. And then V9 is placed in the left paraspinal region, which is literally just underneath the end of the left scapula, right next to the spine, in that little meaty space. When you're looking at a posterior 12 lead, you're looking at 4, 5, and 6. You label them 7, 8, and 9, and you're only looking for 0.5 millimeter of elevation. Normal 12 leads, you're looking at 1 or more. For posterior, all you need is 0.5 millimeters of elevation in these 3 leads to diagnose a posterior MI. Q waves in these leads also is a good confirmation of infarct, but you might not have them. Typically, you see Q waves with the elevations. And remember, the posterior 12 lead is if your lateral leads are infarcting, you should be doing a posterior just because it's all the left circumflex. Yeah. And that's what's feeding off of the left coronary artery. So this guy, what I'm assuming, I didn't ask which specific, like where his clot was, where his blockage was, but you can guarantee it was high up on the left coronary artery because the septal wall gets fed by the left descending, the anterior wall gets fed by the left descending, and then the whole lateral wall and posterior wall get fed by the left circumflex. With the with the left portion of the inferior wall gets fed by some of that left circumflex as well, and all of that was infarcting, more or less. So it had to be high up before they split.
So did you say he just went through a stent, or did he have a full cabbage?
I don't know. The only thing I was told was that he was catheterized. So I don't know if it was just stents placed or if he got a bypass.
Opened up. Yeah.
That I don't know.
Based on the severity, it sounds like it should have been a bypass.
Yeah.
Of course, I'm not a cardiac surgeon, but just
You should
based
be.
on it-
She'd be so happy.
I think
She
I'm
could
ready
stop
for
working.
it.
Yeah.
She could. She could.
But yeah, so, ultimately where the really big educational point that I want to hit home on is knowing the anatomy of where the coronary arteries are and where they feed will allow you to be 8 steps ahead of where this patient is going. So knowing, like, okay, we have lateral wall, anterior wall, septal wall involvement, it's all of this high stem, left coronary artery. Where does that go next? Am I going to lose blood pressure? Maybe. Am I going to lose my heart rate? Maybe not. But I might, I'm already losing squeeze. I might have to hang a pressor. Like, I might have to do AMI. Like, these are things that just looking at the anatomy and taking that time to sit there and go, okay, cool. I'm looking at my 12 lead. I'm seeing stuff. All of those elevations look really bad, but what's actually happening?
Yeah.
Right?
There's still an
And what's gonna happen
underlying
next.
dysrhythmia.
Right. So, like, one of the big things that I see a lot of, like, brand new providers do is they see a 12 lead and they go, okay, cool, there's elevations, and then they throw it away. And that's it. It's like, yeah, you don't have to pick out, is there S waves? Are there this waves? Is there delta waves? Is this, you don't have to do that. Butch will do that.
Yeah, he will.
Yes, he will.
And he will.
But Scarboza, let me know.
Right. But
Yeah.
Let me know.
but if you take, like, nothing needs to happen while you're looking for 30 seconds at that 12 lead. And you're going, okay, there's an elevation here, 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 and here. That's what's being affected. Where is this going to progress?
Yeah, I agree with that.
And looking at old 12 leads and going, okay, this one happened 5 minutes ago. It was 4 millimeters in V4, and now it's 8
Right.
in the same lead. Like, we're getting worse. What's going to happen?
Right.
We're
And you have a
treating and it's
significant
getting
period
worse.
of time before you get to the hospital. So you have
Right.
a lot of time to be able to do all of these things and check all of these 12 leads.
Bingo, and don't forget to label them. If you do a right side and a posterior, don't forget to label them. That really helps the docs out, and it helps you in charting. So I've done that where I'm like, I don't remember which one was which.
Oh, no.
Yep, the one that looks different. That's usually the
That's
one I
it.
pick, and I'm like, I think it was this one. I hope. Exactly. So anything for you guys to add?
No, I think we hit the nail pretty much on the head with pretty much everything,
Gerard, do you have anything to add?
Yeah, no, I've kind of actually been thinking back to like his initial onset, and it's
Yeah.
kind of been gnawing at me this whole time. Like, is he a guy that just doesn't go to a doctor, and that's why he has no history, or is he go to a doctor and then
Has no history.
this just happened as he got the fucking golden BB,
Right.
And what
Yeah.
is his bill?
Because
Like, it's-
my question was, because our initial rhythm coming out was, did he ever? I don't remember. Did he ever convert to normal sinus?
No. So he was sinus tach and then AFib.
Okay. Yeah, so I was just wondering if maybe he does have AFib. Maybe he threw a clot. Maybe that's
Yeah.
why we've got this occlusion that's basically stopping the blood flow all over the place.
Oh, yeah!
You got a great look from Ariel, so I'm throwing you macho on that one.
Thanks, brother.
Yep. But
Yeah, no, it's just been sticking in my head. I'm like, yeah, that's a question I'd love to know.
yeah, and I think one of the things that we brought up was assessment. Really, assessment and questioning. There were lines of questioning that just weren't done
dude.
here.
Once I got him back, dude, I'd have been fucking chatty Cathy. I'd
Yeah.
have been up his ass and down one side and up down the other, just freaking bugging the shit out of him.
Yep.
I'd wanna
Tell me
know-
more.
I want to know what he does there. Is it strenuous? Is he
Yeah.
lifting
I
heavy
think a lot of
Right.
it was they got Johnny Whoops with all the sound and the commotion,
Yeah.
and they didn't know how to handle that stress factor.
And
the
then he
current
codes
situation.
again.
Right.
Yeah.
And they're like, and then it's like, what the fuck?
Yeah, so now you are
know?
freaking out internally, like, okay,
Yeah.
this guy is super serious at this point.
And I
he
mean-
was to begin with, but now
Right.
he's recoding. So.
Right. And realistically, we've all had people die in front of us.
Yeah.
No matter how prepared you are, like, it's still, oh shit.
Your
like,
stomach drops, everything
right.
clenches.
It's that pucker factor,
yeah.
like, okay,
What's next?
I have to breathe for 2 seconds
Yeah.
to reset to figure out what I need to do. We all know what we should do, but it takes us a couple steps to be able to do it because we're like, oh shit, what just happened?
Yeah.
You know, so yeah.
And it's even harder when it's somebody that you were just talking to,
right.
you know, because it's like, because I know, you know, we all know signs and symptoms. We all know, you know, what it looks like and how to jump on it. But there is going to be those few seconds where your brain is still just saying, this is not happening.
Right.
Yeah.
You
I was
get
just
the
talking to the motherfucker. It's got to be something else.
Like
You know?
I was telling Turk, I had one lady who had really no complaints. I believe she was just a lift assist at the time. She just slid out of her chair. We ended up talking her into going just to get evaluated. Stood her up, sat her right on the stretcher, and then that was it, coded. But she had no difficulty breathing, no chest pain. She looked not sick, had no complaints, but all of a sudden, out of the blue.
Yeah.
Just like that.
Boom.
So it
Done.
happens. It happens.
Yeah. You know, it's a phenomenon that's no one is built and prepared for.
Yeah.
It really is. You know, and so I was looking at
Yeah, no, I had one like that too. That just always sticks in my head. It'll never leave my brain. You know, diff breather, get there. He's breathing heavy, but you know, he's talking. He's using full sentence. He's talking to me.
Yeah.
So I said, okay, well, let me get some oxygen on you. And I turned to get the oxygen, and all of a sudden, I hear a thump, and I turn back and look, and he just flopped straight back into the freaking sofa, and his eyes were completely rolled back in his head.
Yep. Just gone.
That happened to me a few
And
weeks
yeah,
ago
it's
too.
like, there was like 2 or 3 seconds where I was just like, hello?
Yeah.
It's quick.
I was
Yeah,
just
it's
talking
that
to
real
you. What the
quick.
fuck?
Yeah.
You know?
So one of the things that I just thought of looking down at the soundboard here was, Gerard, you didn't bring it up, and I was kind of shocked and surprised that you didn't bring it up, but there was no mention whatsoever for
Get to the chopper!
at all. Now,
I thought about it.
40
but-
minutes
but-
Yeah, it
is
is a
on
long
the
time.
cusp, right? They code.
Yeah, I was thinking about it,
They-
but then I was like, yeah, they're already rolling, and the story was going, so I was like, fuck it. And why detract it?
Because it's you.
Because
and that's what
me,
do.
I'm always going to think of a helicopter. It's
I
just
know.
a given.
I know.
Oh, that's a good point, especially if they got him back and we have good ROSC. At this point, we can meet up
Absolutely.
with a helicopter and fly
Right.
him out.
But at the same point, I do see, like, I would see the argument of you're 40 minutes out, which is just on the end of the time cusp for this is when you should utilize us.
Yeah.
And we're already in the truck. We
Right.
could be there before
And you got
they
to
could.
think of lift time.
right.
and-
If you would have called for it when you got there, getting out of the truck, said, hey, spin us up a bird, and we'll get back to you.
Put them on
You
standby,
know, that's
and then
what-
just
over us.
cancel.
That's one thing.
Yeah.
You know what I mean? Yeah, that's one thing. It's something else where now you've done all this. You're in the truck. You've done CPR twice. You've shocked them. All this good stuff. Paramedics is there. Yeah. Now you got 40 minutes. What are we going to sit here and wait? No,
Yeah.
we're going to go.
Yep.
I agree with that.
Agreed. So, we're going to wrap up with that. Thank you guys for bearing with all of us in our, crazy scheduling conflicts. Hopefully by the end of this month, it goes away. I have been assured that Emily's schedule is going to be freer in July. Kelsey almost tests out in a month, so she should be free. And then my home buying and selling at the same time has been ridiculous, but it should be over shortly. So yay. And then, Gerard, you're going to be hosting the new bunker, which is awesome. So that, you'll see how happy he is about it. He sounds fucking thrilled.
No more flight
Outstanding.
simulator.
So till next time, guys, thank you for, again, bearing with us, and we'll see you on the 15th.
All right, donuts.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.